Good afternoon. Good afternoon to all my fellow commissioners, and welcome to those tuning in on the live stream. Before I introduce the rest of the agenda, I wanted to acknowledge that this is the first meeting for Commissioner Kirkpatrick. Welcome. And I wondered if you could take a moment to introduce yourself.
Yeah, happy to. Good morning, everyone. I'm Commissioner Kirkpatrick, appointed by the governor for the Helpline seat. My experience, I'm retired now, but prior to that, my experience spanned 40 years, both healthcare delivery and on the Helpline side, starting way back with Kaiser Permanente, and most recently with Point32 Health, where I was the chief financial officer. I'm delighted to be joining the commission and look forward to supporting the commission and fulfilling its obligations. Thank you.
Thank you so much, and thank you for serving. I look forward to working with you. So let me take a moment to review our agenda for today. We're going to begin today's meeting with a preview of the 2025 healthcare cost trends hearing, which is going to take place on Wednesday, November 12th. The presentation is going to include background on the hearing and an overview of our plan and agenda for that day. Then the HPC Healthcare Transformation and Innovation Department staff are going to provide an overview of our investment program portfolio and preview a new program that's in development. After that, staff from the Office of Pharmaceutical Policy and Analysis and the Research and Cost Trends Department will share findings from the latest issue of the HPC's Data Point series, focused on pharmacy deserts. And the report is called When the Closest Pharmacy is Too Far, Mapping Pharmacy Deserts in Massachusetts. We'll then preview select findings from the 2025 Healthcare Cost Trends Report, the HPC's annual publication, and then hear an update from the administration and finance, including an overview of the fiscal year 2026 HPC operating budget, and commissioners will be asked to vote to approve the agency spending plan. We'll conclude with agency updates in the executive director's report, as always. Our first order of business is to vote on the minutes from our last board meeting, which was September 18th, 2025. And Colleen, can I turn it over to you to take the vote?
Absolutely. I will be handling the roll call vote for the minutes. Are there any amendments to the minutes? Seeing none, I'd like to ask for a motion to vote.
So moved.
And a second. Thank you so much. We'll start asking each commissioner present to vote with Chair DeVoe.
Aye.
Vice Chair Cohen.
Aye.
Commissioner Cotterell.
Aye.
Commissioner Erickson is not with us yet. Commissioner Kirkpatrick, I'll ask you to abstain as this is your first meeting. Commissioner Leibman.
Aye.
Commissioner Walsh.
Aye.
Commissioner Wilmoth.
Aye.
Commissioner Caljo.
Aye.
And Undersecretary Harding.
Aye.
Thank you.
Thanks so much. And now let's move to a discussion of the plan for the healthcare cost trends hearing.
Well, I'll kick off this agenda item. Good afternoon, commissioners. It's great to see you all for this virtual meeting. And members of the public, thank you for tuning in and for your continued engagement and interest in the work of the HPC. So, as we discussed at our last meeting, the HPC, we organize our work into these 4 levers of change. And at today's meeting, we're going to be touching on each of these levers, and we're going to start today with our important role as convener. So in this role, the HPC, as an independent state agency, we bring together experts, market participants, members of the community, and others to discuss challenges and opportunities in our healthcare system, identify solutions, and solicit commitments for shared action. So our most prominent activity each year as a convener is the annual cost trends hearing, the infamous Super Bowl of healthcare in Massachusetts, and it's our biggest event of the year. And so to tell you more about the agenda, I'm going to turn it right over to Colleen.
Hello, thanks so much, Director Seltz. For those joining for the first time, my name is Colleen Elstermeyer. I'm the Deputy Executive Director of the HPC. I've been with the agency 13 years in January, coming up this year. And I am very pleased to discuss with commissioners today the HPC's 13th annual healthcare cost trends hearing. This hearing will be held on Wednesday, November 12th at Suffolk University Law School in downtown Boston. Breakfast and registration will start at 8:30 a.m. The agenda kicks off at 9 a.m. and we plan to adjourn at 4:30 p.m. As our commissioners know, the purpose of the annual hearing is to examine drivers of healthcare costs and discuss opportunities for improving care and reducing costs in the Commonwealth's healthcare system. The format is really unique. It's a key mechanism of our convener lever. It's not quite a conference. It's not quite a hearing. It features live testimony from key stakeholders, including hospital executives, health plans, community leaders, all of whom are required to testify under oath before you and will answer your questions, as well as questions from the Center for Health Information Analysis and the Attorney General's Office, who are our co-hosts for the event. This year's theme is working together to safeguard the Commonwealth's commitment to healthcare affordability, access, and equity. In other words, how are we as a Commonwealth and a community and an industry dealing with the impact of federal policy changes and overall system instability while maintaining a laser focus on Massachusetts values like affordability, like innovation, and access to the right care, the right place at the right price. The unique factor this year, besides having a brand new HPC Board of Commissioners on the dais, is that this is the first year since the passage of the two healthcare bills that were required to call for testimony participants from the pharmaceutical industry and private equity actors as well. We discussed the new laws in detail at the September board meeting. They require new testimony from these additional market participants. So significant equity investors, pharmaceutical manufacturing companies, PBMs, and other state agencies. Those are all new this year. Not to say we haven't had representatives participate from all of these sectors in previous years voluntarily, but this is the first year that we're required by law to call them to testify in person or via written pre-filed testimony to the commission. So we're really looking forward to opening up this conversation, hearing from some new voices this year. And on the next slide, I am pleased to officially announce the agenda and participants for the hearing. So as always, we will kick off with welcomes and remarks from elected officials, and then we will begin with the panels. This year, the structure is 5 panels and 1 guest speaker. And I think we've really invited a great mix of people from the broad swath of the healthcare industry and the community. So starting with panel 1, this is a call to action, community and clinician voices on threats to access, affordability, and equity. So this panel will feature a representative sample of community and business voices and clinicians. This is the frontline experiences panel that we always kick off the hearing with. Kick off the day, set the tone, frame the rest of the hearing. We'll have a small business owner who's been a key critical voice about healthcare affordability. We'll have a family medicine doc. We're having other clinicians in the behavioral health space, people who are working in the community. I don't have names here today, unfortunately, but this panel is still coming together and we're going to be announcing the participants next week. After panel 1 is our guest presenter, who is, I'm pleased to announce, Audrey Shelto, the head of the Blue Cross Blue Shield of Massachusetts Foundation. We've asked Audrey to speak to exactly what is happening in the federal landscape. What's the impact on Massachusetts? She'll really provide the most up-to-date information to set up the next panel, panel 2, state policy response to federal action, preserving healthcare access and equity. Here we're really looking for the wide-angle view of the response and the position that state leadership, including Mass Health, including the Health Connector, as well as the current chair of the Mass Hospital Association and the head of the League of Community Health Centers, are taking to preserve access and protections for our citizens, as well as keeping an eye on our health policy goals. We've also invited the head of Healthcare for All, the state's leading healthcare consumer advocacy organization, to participate on this panel. And really, we're asking Amy to talk about how we're going to keep people covered and keep people healthy. We will feed you lunch. And then after lunch, panel 3, there's going to be a mini panel. This is our Innovation Insights panel. This is going to showcase the innovative hospital at home programs at Mass General Brigham and UMass. We released a really well-received policy brief last month on this topic. And here we're really looking to show tactical approaches from industry to address hospital capacity, workforce crisis, as well as the potential for cost savings. But also back on the general theme, hospital at home is also caught up in the federal government issues right now. It does require congressional action to continue because the Medicare waiver expired. So really interesting there. On the next slide, to frame up the rest of the afternoon, Director Seltz will do his annual presentation, grounding the afternoon in data and research on cost trends, cost drivers, affordability concerns. And then our penultimate panel, panel 4, is the pharmaceutical market trends panel. Here we have a pharmaceutical drug manufacturer in Eli Lilly. We have a PBM, Optum Rx. We'll have ICER. We'll have a health plan, Point 32 Health, and we'll have the Group Insurance Commission, which, for those who don't know, that's our state employee and retiree health insurance and benefits purchaser. This panel, really, we're asking them to focus on the evolving dynamics in the pharmaceutical market, the role that all these different organizations play across the pharmaceutical ecosystem, and really asking them to address drug affordability and equitable access. Last but not least, panel 5, this is the CEO panel. We always end with this panel. This year, joining us are the CEOs of Blue Cross Blue Shield of Massachusetts, Fallon Health, Beth Israel Lahey Health. Also joining us for the first time is Doug Howgate from the Mass Taxpayers Foundation. Doug is a state and policy budget expert. And we're working on a 5th panelist for here too, either a community health center or a high public payer hospital. We'll conclude with reflections and discussion from you, our Board of Commissioners. And then finally, any public testimony, anyone from the public is welcome to sign up to testify at the end of the day. So that's the agenda. I think I hope we have a good geographic balance, diversity balance, industry balance. It's like putting a puzzle together, trying to represent the Massachusetts healthcare community. But I am happy to pause here, take any questions, and also happy to turn it back over to Chair DeVoe to tee up any discussion you have. We welcome your thoughts on priorities and goals for the hearing, any themes you want to tackle, anything of that nature.
Any comments or questions for Deputy Director Elstermeyer?
Yeah, Deputy Executive Director Elstermeyer. First off, congratulations to you and the team. This is my first being a commissioner, and I applaud the robustness and the topics. And this is not easy to pull together. So I applaud you and the team. This is a fantastic lineup. I'm really looking forward to the meeting in a few weeks. The only question I have, because of the hearing and the health cost trends setup. Just curious on the choice to have Executive Director Seltz's presentation in the afternoon and not have it earlier in the day. It's the trends in Massachusetts and imperatives. It just seems like that almost would be the keynote to start the day, but I'm sure you have thoughts on why you've chosen this ordering. I'm just curious.
That's a great question. We have certainly done that in the past and have had David Seltz and sometimes Dr. David Auerbach as well present together to kick off the day. It was a matter of timing and placement this year. I'll be totally honest about that, but I will take a look at that and think about that. Thank you for that comment.
I'll just offer additional thoughts. First of all, thank you again for creating such a vibrant panel discussion that I think the topics are straight on to the challenges that we have. I think we're obviously expecting an interactive discussion within a world that's really dynamic right now. And I guess I would just try to continue to drive towards having concrete and identifiable ideas as folks are talking about their own experiences navigating the different panel topics. and move folks towards thinking about concrete and identifiable potential solutions or thoughts for collaboration in the future. These discussions are always really good, and there's always a part of it where folks will want to say, this is what I'm seeing on the ground. This is how it affects me. But I think it's also really important to then translate it to that last step of, and here's what we can do together to help advance, for example, affordability in a time of potential uncertainty or real uncertainty for most. So that's my only observation, but great job.
Thank you.
Good point. I think the focus on what each of these leaders in their organizations can do to drive affordability and what they can do to collaborate around affordability will make for a productive discussion. Good point. Other thoughts or questions? The timing of our hearing this year, I think, could not be more useful, given, as you look at each of these topics, how much each one is at the forefront of the thinking of those involved in healthcare in the Commonwealth, and how they'll benefit from hearing the current view. Commissioner Harding?
Thank you. And just, underscore what everyone has said, an amazing agenda. One thing just to note, in case people might have missed the news, Amy Rosenthal, currently Executive Director at Healthcare for All, will be testifying. And I think 5 days later, officially, she joins the Executive Office of Health and Human Services as our new Undersecretary for Health. So she gets to represent Healthcare for All. And then, of course, within several days, she'll be a part of our team over here. We're very excited to have her on board.
Thank you. That is incredibly exciting. Any other comments or thoughts? Well, thank you. Thank you so much. And to the leadership of the HPC team, great job putting this together. As each of the commissioners has said, it's as Deputy Ostermeyer said, it's a puzzle, and this was a beautiful puzzle this year.
Thank you.
Really well done.
It's really a team effort, I have to say. I do have 2 more slides, just a little bit of business I want to alert the commissioners about, Madam Chair. Each year, we also call for written pre-file testimony to inform the hearing. This actually gives us an opportunity to engage with an even broader range of people than those just called to testify in person. So, as discussed, this being the first hearing since the healthcare bills, we're required to add a bunch of new people to the PFT. So MSOs are on the list, real estate investment trusts are on the list, all kinds of private equity actors. So we're planning to publish some high-level findings and analysis from the PFT as part of our hearing materials. That'll be for the public as well. And I've just listed some of the topics here that we're asking them to address: federal policy changes, workforce challenges, prescription drug trends, for example, this list. We're going to keep updating our webpage as the testimony submissions are received, so keep refreshing. And the deadline is Friday, October 31st, Halloween, can't miss it. If anyone has any questions regarding pre-file testimony or would like to sign up for in-person testimony, please contact hpc-testimony@mass.gov. And then finally, the last slide, just wanted to say this agenda is now live on our website, so you can see it there. There are all tons of logistical information there. You'll find the live stream there, the registration there. In-person registration is almost full. It might actually be full, so if you haven't registered, register now. And we're really looking forward to this event. So thank you so much. Back to you, Chair DeVoe.
Thank you. Wonderful. Our next agenda item is an overview of the HPC's past and current investment programs. And I want to turn it over to Executive Director Seltz to introduce the topic.
Thank you, Madam Chair, and thank you, Colleen. Great presentation, great agenda. So as Chair DeVoe said, for the next part of our meeting, we're going to be focusing on our investment programs. And as we go back to our 4 levers again, we're going to be focusing on HPC's role as a partner. In this role, the HPC promotes the delivery of effective efficient, equitable care by collaborating with healthcare provider organizations and other stakeholders in investment programs and in certification programs. We evaluate and disseminate lessons learned, and we partner with organizations and work towards shared goals. As part of this work, the HPC is an investor or a grant-making agency, and we support healthcare providers in the implementation of innovative care delivery models and support their transition to value-based payment and accountable care arrangements. So in establishing the HPC, but all the way back in 2012, the legislature understood that many providers, particularly lower resourced community hospitals, would need support from the HPC to build new capacities and test new models of care. And so as part of the bill that established the HPC, the legislature also set aside some funds in a trust fund to be for the HPC to distribute through competitive processes for selective goals. Robust technical assistance, rigorous evaluation of the efficacy of these programs, and a commitment to sharing lessons learned widely have been hallmarks of the way that we have run these investment programs since the beginning. In the very early years, we had a number of larger grant programs that were really focused on community hospitals. Our flagship program was our Community Hospital Acceleration, Revitalization, and Transformation Program, which we called CHART. And CHART was our first big investment program. And we worked with, I think, close to 30 hospitals across the Commonwealth in the CHART program. I personally have so many fond memories of traveling across the Commonwealth and meeting with the program staff of the CHART programs and seeing how proud these staff members were to be a part of the quote unquote CHART program. In many of these cases, we were working with community hospitals on enhancing their behavioral health care and helping patients with social determinants of health and delivering care in a different way. Many of these programs relied on community health workers in a really robust way. In more recent years, we've scaled back the scale of our investments as we've been spending down from our initial allocation. And we're also being a little bit more strategic around the opportunities where we can provide, a real positive impact on patients, reduce known disparities, and improve the efficacy of our overall healthcare system. So to tell you more about the history of our overall investment program and the current work we're doing in maternal health and some of the work that we've been exploring with Robin Lipson, who is the Secretary of the Executive Office for Aging and Independence, I am glad to turn it over to Taylor Bungo. Hi, Taylor.
Hey, thank you so much, David. Good afternoon, commissioners. As mentioned, my name is Taylor Bungo. I am one of the two directors of the Healthcare Transformation and Innovation team at the HPC. And I've had the pleasure of working on this team for the last 9 years. So I'm excited to present to you today an overview of one of the HPC's cornerstone functions, which is investment in care delivery across the Commonwealth. Next slide, please. So as David mentioned, for over a decade, the HPC has leveraged its trust funds and legislative funding as well to invest in innovative care delivery models that engage hospitals, community-based organizations, patients, and community members in delivering high-quality healthcare that's affordable, accessible, and equitable. And there are several key reasons why our investment program lever is really a critical function of the HPC. First, we use care delivery investments to respond to pressing healthcare challenges. As care delivery challenges emerge, we leverage our funds to respond and ameliorate issues in a tangible way that can be felt by patients and providers on the ground. Those that are experiencing the impact of these challenges. We also use our investment programs to test evidence-based care models and models with novel approaches to addressing issues of access, quality, equity, and cost. And finally, our investments are not only focused on, real-time impact for patients, providers, and healthcare workers, but they're also designed to surface insights that inform broader policy landscape. Our evaluation and learning and dissemination functions work together to identify what we've learned about what works and what doesn't, and ensure that we're able to advance and advocate for policy priorities that are informed by patient and community voice. Next slide, please. So over the last 10 years, the HPC has made a massive impact through its investment programs. Over $90 million invested across nearly every part of the state of Massachusetts. The HPC has impacted well over 200,000 patient lives across 6 different investment programs. Next slide, please. So across these 6 programs, there are many themes that have emerged that reflect important factors of care delivery transformation. And the next few slides are going to show some quotations and reflections from providers and patients about the impact of HPC investment programs across these areas. Next slide. So data collection. Hospital staff have consistently noted the positive impact of our investments on their capacity and capability to collect data. One hospital staff saying here, anecdotally, we could say why patients were being readmitted. Through this investment, we now have that data to back it up. We can go to our community partners and say, okay, you seem to have a higher readmission rate, and work with them to identify why. We really have that data. Next slide, please. Innovation. Staff have also expressed how our investment programs afford hospitals the opportunity to innovate and the resources to do so. One hospital staff person said, we're reaching people who would otherwise not be receiving care. They face barriers related to transportation in very rural counties or anything associated with stigma, shame, or fear. Telebehavioral health removes those barriers, and that is huge. Next slide, please. Workforce. So our programs have often funded workforce roles that don't necessarily have sustainable funding sources, and they often prioritize frontline staff that are representative of the communities that they serve. As one hospital staff said, during the screening process, many patients specifically ask whether the doulas are Black and cite a preference for receiving care from doulas who look like them and share their background and experiences. It's evident that being able to share and relate to similar background and experiences in life, as well as healthcare settings, is important to creating meaningful relationships. And our investment programs allow for that to happen. Next slide. Finally, patient experience has become a really central component of our latest investments. While collecting quantitative data on process and clinical outcomes has always been a key component of our evaluations, qualitative data of patient and staff experience has also become a mainstay of our mixed methods approach. So as one patient said of a staff role that was funded by our program, she did a great job representing me. If I didn't understand something, she would inform my doctors or explain things to me. Just her presence. She didn't take no for an answer. There was one nurse that was kind of rude. My doula was an advocate, and she was really there for me, and she spoke up for me. I'm glad the doula was there to have my back. The doctors and nurses, after my doula spoke up for me, they understood, and some of them did apologize. So as you can imagine, we have a seemingly endless inventory of these types of quotes from patients and providers and frontline staff about the real impact that our investment programs have had over the last decade. And these insights are essential to understanding what the healthcare system needs and how our policy decisions are affecting folks on the ground. Next slide. So this slide, you can see a snapshot of the 6 programs we've been referencing that we've funded over the last decade. And as you may be able to intuit, our topics have ranged from maternal health to the opioid crisis to telemedicine pilots. and many, many more areas. Next slide, please. So let's fast forward to today. Where are we now in our investment program portfolio? So as David mentioned, at a strategic level, we've transitioned from large singular investments like the $60 million CHART program to multiple simultaneous, smaller, and more targeted investment programs. Currently, we are in the implementation phase of a program called HEART-BP, which stands for Hypertensive Disorders Equitably Addressed with Remote Technology for Birthing People. And in addition, as mentioned, we're developing another program called Pathways, or Promoting Appropriate Transitions to Home. So I'll take the next couple of slides to dive deeper into each of these investments. Great. Next slide, please. So as many may be aware, in November of 2023, the Department of Public Health issued a report reviewing maternal health services in Massachusetts. And within that report, there was a call out regarding complications from hypertensive disorders of pregnancy. Not only are they a leading cause of SMM and postpartum readmissions, they also account for half of maternal deaths in the postpartum period. Within that same report, the Department of Public Health issued a commitment and a call to action to implement remote blood pressure monitoring programs across the Commonwealth. Next slide, please. So in alignment with the priorities of the state and from our deep expertise in the maternal health realm from previous investment programs, the HEART-BP program emerged. And the program aims to accomplish several different goals, as you can see here, including access to remote blood pressure monitoring technology and support for birthing patients, a focus on mitigating inequities in access, outcomes, and experience, a reduction in avoidable readmissions related to hypertensive disorders of pregnancy, and collection of both qualitative and quantitative data to make the case of sustainability for these models. Next slide, please. This program is a $1.5 million investment across 5 different awardees spanning a wide geography of the Commonwealth. And you can see the awardees listed on the bottom right side here. We are currently in the first half of a 30-month period of performance and really look forward to following the success of these programs and sharing with you and more broadly our findings over the next couple of years. Next slide. So in the final portion of the presentation, I'll share about our investment program work that's currently under development, one of which is the Pathways program. Next slide, please. So the origins of this program are responsive to data that consistently demonstrate the need for more timely, successful patient discharge to a home or a community setting. As noted by MHA's transitions from acute care to post-acute care task force, each day there are 2,000 patients on average that remain hospitalized despite being medically ready for discharge. And HPC's analysis of CHIA data shows that lengths of stay greater than 30 days are increasing as a proportion of hospital stays, and they account for half of the growth in bed days since 2016. In 2022, the Executive Office of Aging and Independence launched an investment program to promote partnership between aging services access points, or ASAPs, and acute care hospitals across Massachusetts to facilitate timely, successful discharge from hospital to home and community settings. Next slide, please. This program, called Hospital to Home Partnership Program, embedded a home and community-based services liaison within hospitals using ARPA dollars. And the program was incredibly well received by hospitals and ASAPs alike, and specifically called out by the Massachusetts Transitions from Acute Care to Post-Acute Care Task Force as a model that should be sustained beyond AGE's initial program. So after conversation between the HPC and AGE, and in the absence of additional funding to support these important partnerships, the HPC proposes to provide bridge funding in the way of an investment program to support new and existing models like this one. Next slide. So the Pathways or Promoting Appropriate Transitions to Home program would support the position of a home and community-based services hospital liaison through partnership between eligible community hospitals and ASAPs. In addition to continuing to support or sustain these partnerships, Pathways would also support appropriate institutional diversion and timely coordinated discharge to home and community settings. There'd be a major focus on the evaluation of this program to demonstrate its value and the case for long-term sustainability of this model. Next slide, please. At a high level, we're discussing funding of up to 7 awards at a total program cost of $300,000 per awardee for 2 years. And the HPC would fund and implement the Pathways program in close partnership with the Executive Office of Aging and Independence, with an estimated launch date in 2026. Next slide. So this slide provides an overview of the current timeline for the development, finalization, and launch of the Pathways program. I will also mention that in addition to the Pathways program, we're also exploring the possibility of another investment program focused on multi-level interventions that encourage close partnership between hospitals, patients, and communities. Next slide.
One moment, I think we've got
sure.
a question from Commissioner Erickson.
Sure,
Sure.
love to chime in. So
Yeah,
thank you for taking us through this program. It seems like I'm paying close attention to like what we can best accomplish with the remaining funding we have, because we can't support this for everybody. And wondering about the importance of evaluation here and the design and putting that in the RFP, that these would be rigorously evaluated, perhaps using randomization so that we could really identify metrics, identify what, is it leading to cost savings? Who should be paying for it? If it is leading to cost savings, I think the best way to take $1 million and support this program is to make the strongest possible case that it's really good, or it needs to be altered in response to some really clear data. So I guess I'd love some more detail about the evaluation plan, the metrics on which it would be evaluated, and how we'd actually see like a causal impact of this on outcomes.
Yes, absolutely. I love all of those points because they're in direct alignment with what we're planning to do here. So as mentioned, evaluation has always been a core component of our investment programs. In Pathways in particular is no different. We're really interested in as rigorous evaluation as possible. That would include, as mentioned, both quantitative and qualitative metrics. On the qualitative side, interested in getting data from staff experiences in the discharge space around how this program really adds value to their experience in the workforce, as well as patient and family experiences of a more coordinated process. And on the quantitative side, we're looking at things like length of stay, readmission rates, a number of different quantitative measures to really prioritize making the case that this is a really valuable program that should be sustained beyond this investment. Grants are one of our levers at the HPC. They have a limitation, as they all do, in being time-bound investments. But one of the things I think that's different about the HPC in particular is we're really interested in leveraging our data and making the case for sustainability that outlasts the grant period, and making changes that are happening at the institutions that last far beyond our dollars do.
Thank you. I'd love to talk with you a little bit more about the kind of RFP design there on evaluation. I think a challenge I've seen with some of the CMS evaluations is that they don't bake that into the design of the grant, and then they don't have a good design ex post to really suss out what was the implementation, what was the effect of this program versus selection into this program.
Yeah, we'd welcome your input and advisement. Maybe we can reconnect offline. Folks can help us do that, and that's a great place to make sure that we have all of the kind of pillars to hold folks to our evaluation plan. So definitely would love to continue the conversation.
Just a follow-up to that. It's nice to have the evaluation data to determine good outcomes, but what beyond what kind of efforts to support or more spread? Like I'm looking at the hypertensive study that's happening with pregnant women now, and if the outcomes are good and the results are good, how does that translate into really technical support to spread through other organizations, just so that it goes beyond the 5 core that are in there now?
Absolutely. Thanks so much for that point. So that's really where our learning and dissemination functions come into play. In the HeartBP program specifically, we are collaborating with PinQuin in particular to help provide some technical assistance. And we know they have far reach, and they've also had experience doing some of this work. So we'd certainly, we're already kind of building that network of folks that are implementing and learning from each other here. Our current investment program awardees are learning from their prior awardees about how to do this work well. In addition, when the implementation of an investment program closes, our work is just beginning with regards to the learning and dissemination function. We often seek out opportunities for webinars to disseminate the findings. We'll often feature the awardees themselves because they're the ones on the ground doing the work and know how to best describe the challenges and experiences they've had. In addition, we would want to develop a number of tangible outputs, both to disseminate on the website and through our newsletter, and perhaps back through the legislature to really get the word out about what's worked and how folks have done this. So those are all avenues that we use.
Just to add on to that, Taylor, and Commissioner Taylor, you mentioned this earlier, but there is also kind of a link back to the broader policy agenda of the HPC. And so we may, through using this as an example, maybe there are recommendations that we have around commercial insurers supporting remote technology. Maybe there are policy recommendations that we make to the legislature around policy changes that would enable the spread of these care models to all different types of providers. Maybe there are policy changes that we would make in coordination with the Medicaid program. So there are sometimes policy barriers that we identify through the work in these programs that then we can feed back up into kind of our broader connections and thoughts around what are those. Is it a payment issue? Is it a workforce issue? What can we think about from a big picture standpoint to make scalable change?
Yes, thanks so much, David. That it also reminds me of part of the design of the HeartBP program was several meetings with the Medicaid folks to talk about their reimbursement of remote blood pressure technology. And with that in mind, we know kind of the different staff and role types that are reimbursable within the care model. And in fact, some of our awardees are doing novel things, perhaps including a different type of staff as the receiver of the data for the remote technology. And so there are things that are different about some of the models that are being tried that we hope to learn about and feed that information back to see if maybe there's an expansion of the reimbursement structure now that may benefit folks.
Taylor, great presentation. I just also want to point out for my fellow commissioners that there's a wealth of information about each of the investment programs in the publication section of the website that not only gives an overview of each of them, but also discusses outcomes from each of them as well.
Thank you, Commissioner Cohen. Appreciate that. Are there other questions or thoughts that you'd like to share at this time? This certainly won't be the only opportunity. We'd love to continue our engagement offline, but welcoming, this is our final slide here.
Thanks, Taylor. Great presentation. I just put a plug in for Pathways. I think it's absolutely extraordinary, and I can appreciate Commissioner Erickson's question and agree, but I guess friendly amendment is what's the goal? And when there are 2,000 stuck patients, I think the number that matters is whether we can reduce the number of people that are waiting to be discharged and then ultimately those waiting for care. Having spent the better part of the weekend in an emergency department with a loved one, it's not great care when you're waiting to be seen. And if the only reason that people are waiting is because we can't move people out to other suitable locations, it's a huge issue. And I think it's an HPC issue because it leads directly to affordability. If people are stuck either at the front door or at the back door, the system is paying for them, and that means consumers are ultimately driving up the cost of their care. So I just put a plug in for Pathways. I think it's incredible. It's really good for patients. It's really good for caregivers that don't have to look at people waiting to be seen in hallways, wishing they could be moved to another safer location. So great work on that. Thanks. Thanks to you and the team.
Thanks so much, Commissioner Walsh. Really appreciate those comments.
Thank you, Director Bongo. I think what we're hearing is that given how critical the sustainability of these programs can be, it'll be useful in the future, I think, to get an overview of where do we see sustainable programs as a result of the investment. If they weren't sustainable, why not? What were the barriers? As Director Seltz was describing, those can be real and not always only financial. And then where did the programs become sustainable and perhaps even adopted by others, to Commissioner Cotterell's point. So I think both the individual investment programs and also just a general understanding from you of where we've seen sustainability be helpful in the future.
That sounds great.
Terrific work. Thank you so much. Any last comments on this?
Deb, could I just add, I think this is a great program. I think teaming up with the ASAPs and with hospitals is great. Can I just put a plug in for a focus on behavioral health as well? Because I know for lots of older adults, those are issues, and also adds to Steve's point about the backlog in hospitals. So just add that as well.
Thank you.
Great. Thanks so much.
Thank you.
Our next agenda item is a presentation around the report concerning pharmacy deserts. And I will turn it over to Director Seltz to introduce the topic.
Great. Thank you, Chair DeVoe. So returning once again to our four levers, for the next portion of this meeting, we're going to continue to move counterclockwise through these levers and now focus on the research and report lever. So in this role, the HPC leverages the Commonwealth's rich data and resources to apply novel research methods to develop insights into the performance of our healthcare system, build an evidence base, and present the public with information on timely issues, and aid in the development of data-driven policy recommendations. And so today we have two presentations and really encourage your questions and discussion and insights. So first, we have a presentation on our latest online interactive publication series on pharmacy deserts. And we began this work with a recognition that, these days pharmacies are so much more than a place to get a prescription filled. They're really a community health resource. In our past, in a previous data points, we found that in the past 7 years, there has been a really significant shift in where Massachusetts residents get their flu vaccine, away from the doctor's office and to the pharmacy. And now a majority of Massachusetts residents get their flu vaccine administered at a pharmacy. Pharmacists are also medication experts who aid in medication management and managing chronic diseases such as diabetes, hypertension, and high cholesterol. So in this work, we sought to better understand the geographic distribution and type of pharmacies in Massachusetts and how that's changing over time and for which communities. This first step was really a mapping exercise and a very laborious and time-consuming effort. This will be on our website, and it's going to be an interactive public resource. But we hope that this work sparks further conversation, really beginning here today with you, about what are the implications for these trends for patient access and what policy action should we be considering. So with that as an introduction, I'm glad to turn it over to Yua and Leiden to lead this presentation.
Mentioned hearing from you for the first time, so I just wanted to introduce myself quickly. My name is Yua Huang. I am the Associate Director of our new Office of Pharmaceutical Policy and Analysis. I've been with the Commission for 7 years or so. Some of the commissioners know me, a member of the research team. I've recently transitioned to our new pharma office. Really delighted to be sharing this research with you today. Leiden will be doing most of the talking, but I just want to kick us off with some background on this work. Next slide, please. So pharmacies, as Director Seltz already mentioned, are important healthcare access points. They not only dispense prescription drugs, they offer over-the-counter medications and provide certain preventive services like vaccines. When pharmacies close, patients either have to travel further for these medications and services, or they might forego these therapies altogether, which is why pharmacy closures have been found to be associated with negative health impacts. Pharmacy closures stem from complex and evolving dynamics in both the pharmaceutical supply chain and the wider retail economy. We know from the literature that independent pharmacies in particular face financial pressures because of their lack of economies of scale. We know that press reports, for example, that they are not the only type of pharmacies. Oh, okay, sorry, I will be back. Like my
David
audio.
coming to talk to you about the sound.
Yeah.
Yeah, it's just a little unclear. Like, I don't know. You just need to focus in on where you're talking, I think.
How about now? Better? Great.
That's much better.
Okay,
Great job.
thank you so much. So sorry about that. So I'll start over. As Director Seltz already mentioned, pharmacies are important healthcare access points, not only providing prescription drugs, but also over-the-counter medications and preventive services like vaccines. When pharmacies close, patients either have to travel further for these medications or services, or they might forego these therapies altogether, which is why pharmacy closures are associated with negative health impacts. Pharmacy closures, we know from the literature, are the result of complex and evolving dynamics in both the pharmaceutical supply chain and the wider retail economy. In particular, independent pharmacies face particular financial pressures because of their lack of economies of scale. This is this is why we wanted to do this study to look at, oh, sorry, just one more thing. We know that, of course, independent pharmacies are not the only type of pharmacies that are closing. We know from press reports, for example, that chain pharmacies recently have announced a large number of closures as well. So the goal of our study is really to kind of look at the number of pharmacies and their openings and closures on a statewide basis over time to kind of understand the trends in pharmacies. And in addition, we wanted to know geographically which communities are where patients are facing a lack of access to pharmacies, which are known as pharmacy deserts. Academic researchers have studied the phenomenon of pharmacy deserts. And for example, one study that has looked at pharmacy deserts nationwide found that 46% of US counties have at least one pharmacy desert, and these deserts are significantly more common in high social vulnerability areas. So on the next slide, I won't spend too much time here. This is just a review of the definition of pharmacies that we have identified in the literature. The main point here is that there's not a universally agreed upon definition of pharmacy deserts, but generally speaking, academic researchers utilize a kind of distance-based definition, sometimes in combination with demographic factors when they define pharmacy deserts. You'll see that that's the approach we took as well. With that, I'll turn it over to my colleague Leiden.
Thank you, Yue Huang, Deputy Director of the Office of Pharmaceutical Policy and Analysis, about 7 years here at the HPC. My name is Leiden Marcelat. I am a Senior Manager on the Research and Cost Trends team, and I've been here for 8 years. And yes, I'd like to talk about this analysis where we've done an assessment of the pharmacies that are active in Massachusetts in 2025, the number, the type, just as Yue was suggesting, and the geographic spread, and get an assessment of the access, the communities that are facing low access. On the next slide, we talk a little bit about the data sources and some definitions, and we'll talk a little bit about the methodology in a second. We use publicly available data from the Department of Public Health's Board of Registration in Pharmacy. And this data includes current and historical data on pharmacies, including, license renewal date, license issue dates, expiration and renewal. We also, in this analysis, we exclude compounding, specialty, and provider-based pharmacies that are not open to the general public, but we do include provider-based pharmacies that are open to the general public. And in this analysis, we considered 5 different types of pharmacies. So large chains, these are your CVS's and your Walgreens, the grocery store-based pharmacies, the small chains and the independents. So these are, either regional chains or small one-off mom and pop independent pharmacies. We also have the mass merchant, your big box store pharmacies like a Walmart or a Costco, and then those provider-based pharmacies that I mentioned that are open to the general public. These are co-located and operated by hospitals and other providers like community health centers. On the next slide, we look a little bit at the pharmacy desert definition. So first to note that this analysis was conducted at the block group level. So a census block group is a collection of census blocks, which the blocks are the smallest unit of analysis for the census. And the census block group is a collection of those. These are designed to be about the same size in terms of population, though not in terms of geographic area. And for this analysis, we can consider 3 different geographic levels, rural, suburban, and urban block groups. And they each had different distances, proximity to a pharmacy that we considered 5, 2, and 1 miles. We also made an additional allowance for low access areas, as was common in the literature. So for areas that either had higher poverty rates or lower access to vehicle ownership, we have the distances that we mentioned before. I'm going to talk about how blocks were selected on the next slide, but just before that, I want to note we also did an assessment of near deserts. So these are communities where they're not currently pharmacy deserts, but they're anchored by only one pharmacy. And if that pharmacy was to close, these areas would become a pharmacy desert. So we'll get to the results in a little bit, but on the next slide, we do an illustration of how this work was done. So on the left, in the blue dots, you can see 3 different pharmacies that are in the center of central Pittsfield, Massachusetts. And in the colored blocks in the center show block groups that are partially covered or not covered at all by the pharmacy radius here. In this case, we're looking at a half-mile radius. And you can see that the blocks in green are either fully covered or a majority of the area of those block groups are covered by that radius. And so we use this to get a sense of how well the population is covered by pharmacy access. And so you can see the block groups on the right, where there's only a sliver of the one in the center being covered by that radius, 6.7% of that block group. And then the one to the further right, which is not covered by that radius at all. These are the pharmacy deserts. These are block groups that are only covered by 15% or less. And we say that, you know, the population does not have great, convenient, reasonable access to a pharmacy based on this methodology. We do this at all geographic levels with the considerations of low access, low income that we mentioned. On the next slide, we just quickly want to note a couple of factors that will, you know, affect the interpretation of the results that we'll show you. You know, first, that we assume that all persons are equally or evenly distributed across a given block group. You know, this, you know, assumption is violated in general, you know, in some block groups. But, you know, to be able to, you know, kind of do this analogy to the block group and how much of it is covered to the population, we make an assumption that, you know, proportionally, the amount that is covered by the radius is proportional to the population. And also all of our distances are as the crow flies. So these are straight line distances. We do not do analysis along a road network or how long it actually takes a person in that block group to drive that location. We're purely looking at those radiuses we noted, excuse me. On the next slide, we're going to get, actually, one further slide, please. We're going to get to the results of this analysis. So on this slide, we look at the active pharmacies in Massachusetts. So this is in 2025. And here we can see the different types of pharmacies that we mentioned before. Groceries in orange, large chains in blue. In that lighter blue, there's the mass merchants, the big box stores. In purple, it's the provider-based pharmacies. And then in yellow, those small chain and independent. As I noted, there's 940 active retail pharmacies in Massachusetts. On the next slide, I get to talk a little bit about the trends and how this has changed. And you can see that there's a decline over time. Here we're starting from 2016 to 2025. We're also showing in stacked bar graphs here, each category of pharmacy as well and how those are changing over time. You can see that the largest proportion of these are the large chain pharmacies in blue, and those represented about 61% of pharmacies in 2025, and that percentage was about was pretty consistent across this time period. But what you can see here is that in the early period from 2016 to 2019, there isn't much of a decline. There's actually a drop and then an increase. But in the last 5 or 6 years, since 2019, there's been a 17% decline in the number of pharmacies in Massachusetts. On a proportional basis, small chain and independent pharmacies and grocery-based pharmacies declined the most at about 20%. Large chains were pretty close at about 18% there. But in absolute terms, large chain pharmacies dropped the most at 123. And I'll also note that provider-based pharmacies actually grew during this time, about 75%. On the next slide, we look at this, we look at the closures and the openings specifically that underlie that previous graph. Here we're only looking at 2018 through 2025. And it's worth noting that we're looking in 2-year chunks. When licenses are renewed in this data, we're only able to see 2-year windows because licenses are renewed in 2-year chunks. And so what you can see from this graphic, in blue, we show the openings, and in orange, the closures. And you can see that though there are openings and closures in each period, that the largest number of closures were in the 24-25 period, which was also the lowest number of openings. On net, we've lost 220. We've had 227 pharmacies close. That's 142 openings versus 369 closures during that period of time. On the next slide, we also look at these closures by that same categorical look in stacked bar graphs. So for the earlier period in 2018, 2019 at the top, you can see in that lighter blue that mass merchants had the largest chunk of closures during that time. But in the most recent period, large chains had the largest decrease. And I showed you that before, that we saw it over the full period, about 120 large chain pharmacies were lost. Now we want to get into, on the next slide, the pharmacy deserts themselves. So with no further ado, we'll talk about the pharmacy deserts that we have in Massachusetts. We using the same criteria we noted earlier, identified 432 communities, block groups, where the population had this low to lower access to pharmacies. We found about 580,000 people were in an area that constituted a pharmacy desert. This represents about 8.3% of the population. And we noted that there was a large decline following 2019. We did also investigate the pharmacy deserts in 2019, what would have been pharmacy deserts in 2019. And we found that the number of the population in a pharmacy desert has increased by 90,000 people since 2019. You can also see those statistics on the right show that we have pharmacy deserts across every geographic level that we looked. On the next slide, we also do a quick zoom in on Boston's pharmacy deserts. And we found pharmacy deserts, and we also found that about, I think it was about 22 pharmacy deserts in the city of Boston during this time. On the next slide, we also, as I mentioned, assessed the near deserts as well. And we found almost a similar number of these areas as the pharmacy deserts. 416 of the block groups were considered at risk of becoming a pharmacy desert. Again, these are the areas that are anchored by only one pharmacy, such that if that pharmacy was to close, these areas would become pharmacy deserts. Again, you can see that this is widespread across the geographic levels that we looked at. And these constitute about 525,000 people in Massachusetts that are in a near desert. This is about 7.5% of the population. On the next slide, we also do another look at Metro Boston in this same context for near deserts. And there are 46 areas, 46 block groups in Boston that are near deserts. On the next slide, we bring this together, and we'll show you in a second, we'll demonstrate the interactive features of the data points. We'll show you bringing these all together. But if you consider the folks that are both in pharmacy deserts or in near deserts, this constitutes about 1 million Massachusetts residents that are living in a pharmacy desert or at risk of being in a pharmacy desert, which is over 15% of the population. Now I'd like to demonstrate some of the interactive features of the data points. This is the first exhibit that you'll find in the data points. And this shows you those same pharmacies by category over time. And you can use this slider here or the buttons. We started on 2025 because that's the current period, but you can go back and use this slider to kind of see how pharmacies are changing over time. I will note, obviously, that there's a lot of overlap, particularly in the areas with greater population density. So it may be hard to see each color pop out, but you will see this slight decline happening on your screen. And we do see some kind of regional geographic patterns. Pharmacies are, clustered, near population centers. You can see in Western Mass and portions of Central Mass where there aren't any pharmacies at all. We haven't done a full assessment of, why, pharmacies locate in certain areas or not. So we haven't fully characterized why, pharmacies are where they are in Massachusetts, but generally they're around population centers. There is also a help menu to give you instructions about how to use the map. There is a search function, and you can pan and zoom and get some map statistics as well. The second figure looks at the openings and closures, and you can also look at this over time. And you can also look at just closures by themselves or just openings by themselves. And the final exhibit, the interactive exhibit that I want to show allows you to, dig into the pharmacy deserts themselves, as well as the near deserts, as well as layer in our active pharmacies and county lines. If you hover over a given pharmacy desert, you'll get a little bit more information about it. This one is Middlefield, and it constitutes a pharmacy desert, and it's a rural block group. Similar for the near deserts, here we're looking at Monroe, Massachusetts, constitutes a near desert, and it's also a rural block group. If you hit this little pancake button, you can add or subtract layers. I mentioned that you can add pharmacies themselves, so that same look that we showed before. And we can also do an overlay of counties in Massachusetts, so you can get a sense of how they break out. Now, we want to turn back to the slides, where we'll be able to show you a little bit about characteristics of the population that are in these near deserts or in pharmacy deserts. On the next slide, please. Here we break the table up by the geographic levels, the urban, the suburban, the rural, and then we also have each of those broken out by the non-deserts, those near deserts, and the pharmacy deserts as well. You can see there the share in the second column there, the share of each geographic level that is in a pharmacy desert or a near desert. And we wanted to highlight that we found that the deserts tend to be in areas of low population density. So that fourth column there, area in square miles, we can see that pattern at each geographic level. And then we also found on the far right, highlighted in yellow, that in urban deserts in particular, they tended to be in lower income areas within urban regions. And with that, I'll turn back to you to sum up and offer some conclusions.
Thanks. So in conclusion, our research found that the number of pharmacies in Massachusetts have declined by about 17% from 2019 to 2025. 8.3% of Massachusetts residents, that's about 580,000 people, live in a pharmacy desert as of 2025, and that number has increased since 2019. Another 7.5% of residents, about 525,000 people, live in an area that would become a desert if the sole pharmacy in their area is closed. And kind of, I want to close by saying that, you know, this exercise, this mapping exercise, is sort of the first step in kind of understanding where the pharmacy deserts are in our state, and certainly we plan to continue to examine the issue of pharmacy deserts. I think this is really an area where we could leverage the expertise of our research team, as well as the Pharma Office and our Office of Health Resources and Planning, to take a deeper dive in this issue. So I think we'll stop there and invite any feedback and input from the commissioners. Happy to answer any questions about the research, and hear, you know, where you think we should take this work next.
Thank you so much. Commissioner Harding?
First of all, thank you very much. I mean, incredible data, a lot of work in here, but it's also eye-opening. But it does leave me wondering, where does mail order play into this? And can it help to fill some of the gaps or coming gaps that we see in these potential deserts? But what have you looked at that, and what role that plays in the Commonwealth or across the nation? Thank you.
Happy to take this question, and thank you for raising this point. It's a really important dimension, I think, to consider in the context of our research. The use of mail order prescriptions certainly has been increasing, especially since COVID. Overall, it still represents a relatively small share of prescription volume. We've seen data that suggests, you know, less than 10% nationwide. We know that it is not an option for everyone. Not all plans offer mail order prescriptions. The Boston Globe, for example, did really in-depth reporting on the issue of pharmacy deserts last year, and they quoted a patient as saying, you know, she lives far away from a pharmacy, and she was able to get her prescription delivered in the mail through Walgreens for a while, but then Walgreens stopped doing deliveries because of limitations to her insurance, and then she tried to go to CVS, and CVS also didn't do mail prescriptions because of her insurance. So certainly it doesn't work for everyone. It takes some know-how to kind of set up receiving prescriptions in the mail. Mail services might be interrupted or packages stolen. So these are all kind of known limitations of mail order prescriptions. But I think the more important point to consider here is that mail order pharmacies are not substitutes for brick and mortar pharmacies. As we talked about earlier, pharmacies don't just dispense prescriptions. They also, pharmacists can provide medication consultations. They provide services like vaccines. Pharmacies in Massachusetts have a standing order to dispense emergency contraceptives without a prescription, and they stock medications ranging from life-saving naloxone kits to, you know, all the over-the-counter medications that we all use every day. So, you know, I think we view mail order pharmacies as one way that could alleviate some of the access problems associated with pharmacy deserts, but I think it's fair to say that they might not be an all be all solution to pharmacy deserts.
Yeah, good understanding of the issues, and it sounds like that could be an area of future research to just look at what is the availability of mail order pharmacy access and how many people in the Commonwealth take advantage of it, just as a way of understanding that aspect of accessing services, which to your point is a small part of what brick and mortar pharmacies do. Commissioner Cowdrell?
Thank you, and thank you for the research. It's a great example of the HPC's new role with regard to pharmacy, and I think you come out of the blocks really well with this constructive research. Certainly, this is a problem national in scope. Massachusetts is no different than many other states. New Hampshire and Vermont, for example, are really struggling with this issue just north of our border. And I'm interested in learnings that we can take from other states who have grappled with this issue as you continue to delve into it. I know Illinois, for example, and Vermont have advanced some telepharmacy improvements in terms of being less restrictive on the ability to use telepharmacy. And coupled with mail order, it could be potentially a helpful combination of solutions for folks. There are many cases where we can't build a market. And so I think the options of technology could be helpful here. And then I also think that there's some role that we can continue to play with regard to pharmacy benefit managers in the regulation of their networks, similar to how we monitor health plans, carriers, provider networks on a sort of geo-access front. And I'd be interested in learning more about state approaches around that. We at the Division of Insurance have new authority as of next year in terms of the licensure and regulation of PBMs, and it might be a source for further action that we would want to consider in that environment. And then lastly, Amazon is doing some interesting work here in terms of kiosks and the availability of patients to sort of use almost I'd call it not quite a full facility, but an ability for a patient to access pharmacy consultations and services at satellite locations that are not full-scale pharmacies. And then lastly, I think I'd be interested personally in additional research around the independent pharmacy issues and ways that we can help improve the standing of independent pharmacies. So that's a lot, but I definitely am thankful for the work, and I'll stop there.
Thank you. Two more comments or questions before we'll close on the topic. First, Commissioner Wilmes, and then Commissioner Erickson.
Thanks, Chair. I just have a quick comment, which is that I think it will be important going forward to analyze the 340B pharmacies. My understanding from your presentation is that those were largely excluded from this analysis because they primarily serve only patients of the covered entity, the FQHC or the safety net hospital that's providing the 340B. But we do have a lot of 340B pharmacies in Massachusetts. And I was trying to sort of compare the two maps while I was preparing to ask this question, but I guess I'll just leave it at that I think, I would encourage you to sort of do some analysis, try to figure out how the 340B pharmacies play a role in reducing pharmacy deficits, contributing to pharmacy deserts, whatever the research shows. But it's obviously a topic of important conversation for many in the healthcare marketplace in Massachusetts. So I think it'll be important to sort of integrate that ASAP.
Excellent. Commissioner Erickson?
Absolutely. So I think this is a great look at a big challenge our state face. I would love to see a little bit of thought and the next steps, thought and discussion about regulations in Massachusetts and how they compare to other states. Is this something that the state could have a lever that would make it more profitable to open a pharmacy in an underserved area? That would be something I don't know. And or maybe the decline is largely due to a retail decline, and that would be actually a very valuable piece of information to know as well. The other thing is like when we talked about looking at access to mail order pharmacies, we might be able to look at Mass Health, where we have good data on network and network adequacy, and be able to say something about the most vulnerable people's access to mail order as an alternative, though of course noting that it doesn't cover in-person things like flu shots and such.
Thank you. Terrific discussion. Well, thank you so much, Commissioners. And Yue, any final comments or thoughts before we close?
No, just thank you so much for the thoughtful questions and feedback. We are looking forward to continue our research in this topic. So more to come.
Terrific. As you can tell, so are the Commissioners. Look forward to it. Thank you so much. Very important and useful report. We'll now turn to the next item on our agenda, which is to understand findings from the 2025 Healthcare Cost Trends Report. And Director Seltz, can you frame up the topic?
Yes, thank you, Madam Chair. And I'm gonna keep us moving right along in our research and report lever. Here today, we want to share some select findings from our Healthcare Cost Trends Report chart pack. And so each year, alongside our Healthcare Cost Trends Report, we also issue a chart pack. And this is a series of topical chart packs that contain usually around 15 to 20 graphical exhibits, usually with a little bit of text. Oftentimes, these are analyses that we run year over year, update with another year of data. Sometimes we'll add some new methodologies. And so this year, for this presentation, we just wanted to pick out 3 to 4 of these exhibits from each one of the chart packs and present them to you for your insights and feedback, not going through all of the exhibits in all of these chart packs, but really just a selection. So you can get kind of a broad sense of what's in these chart packs as we're continuing to put these together and continuing to work on the final cost trends report, which we hope to release later this year or at the very beginning of next year. At the end of this presentation, I'm going to come back and begin a conversation with you around potential policy recommendations that we may want to include in this year's cost trends report as well. So with that as an introduction, I'm turning it right over to David Auerbach.
Great. Thank you, David. Just a bit about who I am. I'm the director of the research team. I've been at the HPC since about 2014, and I came here by way of first the Congressional Budget Office in DC, and then the RAND Corporation in DC and in Boston. And I have a tremendous team that I work with, and they have done a huge amount of work going into these chart packs. It's pretty much a team effort. Everybody is doing something. And we're really proud of these. I hope you take the time to go through them when you get the cost trends report draft. And I'll just note that people in policy agencies across the country use these. They try to replicate them, and they really find them insightful and great analyses. And they take full advantage of the amazing data resources we have here, including data from CHIA, largely from the APCD, and our discharge data. So let's go through some of them. As David Seltz said, I'm really just going to hit some of the highlights to give you a flavor of the kinds of analyses here, and they'll be in 4 sections. And just another note about them, we're picking analyses that particularly highlight some of the issues in the healthcare system, some of the dynamics that suggest to us there might be opportunities to improve on these main aspects of affordability, access, and equity. So that's really what is underlying the analyses that we choose to undertake and show in these chart packs. Okay, so in the first one, our primary care and behavioral health section, I want to start with This one, which we've talked about in the context of the primary care task force, and we're showing spending between 2019 and 2023 in these three categories of care highlighted: primary care, as you see on the left, behavioral health care, and other medical services, not including prescription drug spending. And the key point here is that primary care spending, and this is per member per year, has been growing more slowly than everything else. 13% compared to a substantial increase in behavioral health spending and in other medical. And so given this lower rate of growth, that is why primary care spending as a share of total spending has been dropping year after year. Okay, next chart. This is a deeper dive in primary care spending that really highlights access and equity and some of the just disparities that we see in provision of primary care and people's ability to receive it. What we did is we separated the state into zip codes and arrayed them by income of that zip code. So we have our lowest income residents on the left and our highest income residents on the right. And we asked what percent of folks in those areas have exactly zero primary care visits, zero primary care encounters with the healthcare system. And you see this pattern that's maybe not surprising, but it's quite stark, that in our lowest income areas, you're much more likely to find people who have had zero encounters with the primary care system over the full year. For adults, 30% versus 20% in those highest income areas. And for children, it's almost 3 times as high. 11% of children in our lowest income areas had no primary care in 2023, compared to 4% in the highest income areas. Okay, and on the next slide. Finally, in this section, this one's somewhat primary care adjacent, but what we're getting at here is the sense that many have that within our healthcare system, it's the cognitive time, it's the face-to-face visits that is largely what primary care providers provide that are relatively underpaid compared to some of the procedural and interventional work. And so what we did in this exhibit is we created kind of an index of procedures and specialty services. And that includes things like drainage of a bursa, treatment of a skin lesion, a nasal endoscopy. And we collected these services and prorated them to 30 minutes of work time. And you can see the average amount paid for that collection of services in the yellow bars, comparing that to an equivalent amount of time spent in an evaluation and management face-to-face visit, 30 minutes of time, so that it's kind of an apples to apples comparison of just how much more are we paying for those kinds of procedural interventions. And you can see the ratio is about 3 to 1 on the right. We also look at how this varies by payer, and there are some differences. With United, that ratio is about 4.5 to 1, and that is as low as 2.7 to 1 for MGB Health Plan. So, this is the kind of dynamic that tends to lead to primary care being less lucrative, less remunerative, and therefore then disfavored to some extent in choices that medical residents make and where to specialize, and in provider systems to prioritize primary care. Okay, let's go on to the next section with some of our commercial price trends.
David, can I interrupt with a
please
quick
do,
question?
yeah, all throughout. Yeah.
On that E&M code data, what's the year study? What's the period of study?
This is a snapshot in 2023.
Okay, thank you.
Sure.
And Dr. Auerbach, one more question on that section. Do we have any understanding of, for the kids and adults who are not having primary care visits, whether they are being seen in the emergency room and whether that's a potential substitute, or whether they're really not interacting with the healthcare system?
That's a great question. We haven't specifically looked at that within this analysis, but I will say that we could, and we'll do that. A couple of years ago, we did something similar where we used the same income deciles and looked at the array of broad categories of care that folks are receiving by that decile. And we found, kind of as you might be getting at, in the lowest income, the use of professional services, which includes that primary care, is lower, yet spending on emergency department and hospital inpatient is higher, so that you see that ratio of more intensive care. And it's not about health status. It's about kind of access to the kinds of outpatient ambulatory care that can prevent these higher cost events later on. So that pattern is absolutely present.
I had a question in terms of the time period for the data. Was this in any way impacted by the COVID era, given that, it was, between 2020 and 2023, and just wondering at that point, as you know, access, staying at home, don't go to the doctors, just wondering, did COVID impact any of the data points or potential outcome?
It's a great question. So far, the charts that I've shown are solely 2023. So I think we're past most of the COVID impact, but some of the ones I'll be getting to will be more of a time trend, and you'll see some impacts of COVID there and in other parts of the chart pack as well. Absolutely.
Commissioner Erickson?
Wanted to chime in and ask about non-commercial payers, government payers. So that's where we might have maybe more policy choices available to us. And how does Mass Health pay for these things? What do we know about Medicare? Medicare is not going to be in the APCD data, so I grant that. But that seems like a useful benchmark too, because those are things that we can directly impact, or that government can directly impact.
Yeah, that's a great question as well.
David, I see Chris Harding's hand raised. I don't know if you were raising your hand to respond to that question, or
I was.
a different question.
I was.
Okay, great. Go ahead.
While I am not the expert in Mass Health, I've been a part of some of these conversations. Off the top of my head, I'm going to say that the rough spend on primary care across all of Mass Health was about 7% last year. And the stated goal, and this is something that the governor stated not too long ago, is getting that from 7% to 10% overall. So there's a pretty big focus from a Mass Health perspective to invest heavily there. And again, I have to reconfirm those numbers, but that's what I recall.
And I will chime in because having looked at the most recent CHIA report that looks at proportional spend on primary care, I'm pretty sure Mass Health was the only market segment where the proportion of spend on primary care increased in the most recent year. And that's in large part to their focus on this primary care subcapitation program. So that their number was going up. The number that David was showing earlier, the decline, that was in the commercial market. But Keith, I don't know, was that question maybe relevant to this payment slide?
Well, I was curious, how does Mass Health pay for specialty care versus primary care, right? So in addition to the fraction of expenditures, what the payment rates actually are.
Right. We haven't replicated this exact comparison, but we could, because we do have the Mass Health claims. So let's we will jot that down and come back to it. But I suspect that Mass Health, I mean, as folks have said, Mass Health's payment for primary care is a higher proportion. So
yeah, and David, I would bet you a nickel that Mass Health has that data, and they'd be happy to share with you. They're tracking that pretty closely.
Mm-hmm. Great. Okay. Great. Okay, let's continue on to the next section. Thank you. Okay, great. All right, so we also spend a good portion of the chart pack tracking trends in prices. Prices have consistently been the biggest driver of healthcare spending over the years, every year that we've been tracking this. And so here, this is kind of the most macro view of prices, where we're looking at price increases from year to year. And you see the years shown in the broad categories of office-based care, hospital outpatient department care, which we call HOPD for those of you who haven't seen some of our terminology, and hospital inpatient care. And just one thing to note here is you can see that those price increases in 2022 to 3, that's the latest year that we have in this data, were higher for the HOPD and the inpatient than in any of the previous years. So that price acceleration does contribute to the faster overall growth that we saw in healthcare in 2023. And just to note, as you see the cost trends report, some of the folks that are new to the commission, you will see a first section going over those broad trends we presented at the benchmark hearing. And then you'll see a topical chapter on cost sharing this year, and then you'll have these chart packs. Okay, so on the next slide, we show some of our deeper dives on prices, where We then go provider by provider, payer by payer, and just a couple examples of that. Here we are choosing average prices received by hospitals for a low complexity vaginal delivery. And here we only chose hospitals with a sufficient volume to be pretty confident in these average prices. And we are showing commercial and Mass Health prices together on this slide to kind of show how those differences shake out. So most important thing to note is the price variation is quite high. It's about a factor of 2 from, you can see the hospitals on the left and then to Berkshire Medical Center on the right. And also note the comparison to Mass Health, which might be surprising to some people. So we've divided the total payment into the portion the hospital receives in the orange and the portion that the professionals, the physicians receive in the blue. And so comparing orange to orange, you can see that Mass Health is actually paying hospitals more than most commercial payers for the hospital portion of the birth. That's shown by that orange line being higher than most of the orange bars. But then when it comes to the total all-in price, including the professional part, most of the commercial total all-in prices are higher than Mass Health, but in some cases not by much. Okay, so that just gives you a sense of those relative payments. Okay, and on the next slide, another aspect of price variation. And so keep in mind that 2 to 1, we see that 2 to 1 variation kind of whatever kind of service we're looking at. Here's an example of now just administration of a fairly high cost drug, Keytruda, in hospital outpatient departments. You see the same 2 to 1 variation in administration of the same exact drug, same exact dose. And the prices that hospitals receive for that drug range from about $11,000 to over $22,000 on the left. And you can see those prices in comparison to what Medicare would pay in that gray line, which is 6% above the average sales price of the drug. And we're also showing administration of this drug can also occur in physician offices. It doesn't have to be in a hospital. And the office price is in the middle there at around $12,000 on average. Okay. And the last slide in this price variation section is something new to this year's chart pack that's interesting. And here we were trying to have a little more understanding of this concept of site neutral payment, which is an active topic of discussion in Congress and in many states. And the idea is, should we be paying the same price for the same service, regardless of where that occurs, where that takes place? And it's fairly well known that for a lot of services that could just as well happen in an office setting or a hospital outpatient setting, we tend to pay more in the hospital outpatient setting. Medicare does this, private insurers do this. But again, it's an active topic of reform. So we wanted to understand just how much more are payers paying when these services occur in a hospital outpatient department. So we created another index, a basket of 25 of these services, things like physical therapy, mammography, a lipid panel, and just said how much are payers paying for the same exact basket based on where it occurs. And so in this case, you see the highest prices are paid by United on the left, and that ratio of how much they're paying in a HOPD versus how much they're paying in an office is the highest. It's about 3 to 1 with respect to United. And then on the right, it's less than 2 to 1 when we're talking Health New England or Blue Cross, but still there's a pretty big differential. And this is a topic that we will come back to in some of our policy work coming up in the year to follow. Okay. I think that's the end of the price section. Let's move on to the next section where we talk about hospital and post-acute care utilization.
And Dr. Allenbeck, just to mention, let's take some extra time on this agenda item, so we don't want to rush through it. So let's take until 2 o'clock.
Great. Any questions on the price section, or should we move along? Okay. Great. Then I will walk through an example because I really like this graphic. What we're showing here is patient pathways through the hospital, and this is a snapshot of the full year of 2024. And what we're showing is really the entire hospital system, in a sense, starting with someone's entry through the ED and tracing where patients flow as they go home or to other levels of care within the hospital system. So you can see on the left, we have about 2.8 million emergency department visits in 2024. About 3/4 of them arrived to the ED as a walk-in patient, about 23% via an ambulance, and 2% in other ways. Okay, so now that is that ED donut there. You can see 70% of those end up being discharged to home. A small number are transferred or leave on their own, and 10% then go to observation, whereas 13% are admitted directly to an inpatient stay on the far right. Of those going to observation status, in the blue section in the middle, 1/3 of them ultimately are also admitted to an inpatient stay, and that's the blue chunk on the right. Okay, and then many on the right, focusing on that, you see that, the orange section, about half of those inpatient stays came from the ED, 13% came from observation, and about 1/3 came directly from the community. They were scheduled admissions, such as a joint replacement, or transferred from another hospital. Okay, so within that universe of our inpatient stays, finally, we can track most of those are discharged to home, but a fair proportion, 20%, go to home health, 11% go to a skilled nursing, and 11% go to somewhere else like a rehab. So I will note one interesting thing that you will also see in the chart pack is in Massachusetts, even though it looks like a minority, for sure a minority of those ED visits end up in an inpatient stay, that is a higher proportion than any other state in the country. And that's something that is just an important fact to know, to think about flow through our system and our overall capacity and use of healthcare. And we've looked at that not only overall as a state, but you'll see hospital by hospital rates in the chart pack. Okay. Any questions on this slide? All right, let's keep going. A few more from this section. Here, we're tracking our total emergency department visits in the state. Here, we're subsetting on just the ones that do not end up admitted to an inpatient stay, so the so-called treat and release, which is most. And again, it might be surprising to some that the number of ED visits that occur in the state in 2024 is quite a bit below the number that we had almost a decade ago. You can see that in the blue bars, tracking those totals per 1,000 residents dropped a ton. There's your impact of the pandemic. They dropped by about 1/3. And they have inched upwards since then, but have not come back to the number of ED visits we had before the pandemic. Now, within these, excuse me, we also track the percentage of those, or the number that are potentially avoidable. And this is using an algorithm that's well known and has been adapted and evolved, and it's using the diagnosis codes and why people are there in the ED. We find that the percentage of these potentially avoidable visits has been inching up, and you can see the orange bars and those percentages there, up to about 40.5% in 2024, which is the highest percent that we've seen in this data. In potentially avoidable ED visits, they point to perhaps a lack of primary care, a lack of access to ambulatory care, and other, the kinds of telehealth or services that can end up avoiding an ED visit when you don't necessarily need to be seen in an ED, urgent care, those sorts of things. Okay, good. I think there's a couple.
David, I just to add, one piece of context in terms of, while the overall rate of ED visits, might be lower than it was pre-pandemic, there's also been a loss of capacity in terms of our hospital system. We had, Norwood, Brockton, Kearney, Neshoba, and so
that's right.
Just want to make clear that the impact on any individual hospital may not feel that way, given kind of how the capacity has changed. And you got a number of questions, so Commissioner.
Yeah. First, Commissioner Calgill, and then Commissioner Kirkpatrick.
Great. Yeah, I think this will be a really important slide to revisit during cost trends, in particular when we talk about the impact of federal law changes in the environment on future utilization at the emergency department. As insurability goes down and access to care goes down from the insurance sector, ED usage is going to go up. That's not good. That's not good for anybody. And it will also likely increase debt at the hospital level for free care. And I really think that this commission should really delve into that and make sure that we understand it and fully deploy any alternative proposals to drive at it.
That's a great point. Thank you. And I will say that we're very appreciative that CHIA is able to give us this data with very little lag, maybe just 3 months lag. We can see the full set of ED visits, and that has been tremendously helpful for our up-to-date reporting on this metric.
Very good to know. Commissioner Kirpan?
A similar comment to the previous one, which is, given that the source is CHIA, you presumably have access to who the insured carrier was behind these patients, right? Or showing up at the ER.
For the most part.
And I'm wondering if one of the roles ought to be for us to give some feedback to those companies that are either not aware or could do something about it through outreach and prevent some of these patients showing up at the ER.
That's a great point. I agree. We should do more of that feedback. Many of them collect this data in some way on their own, but we often have it in a more timely way than they are able to.
Yeah, and that sort of gets into a governance issue, right? I mean, I think this is really rich data for us to utilize and cajole, especially some of the health plans, and make sure that they can demonstrate they're on top of this issue.
Yeah, I think another benefit that we have is we can do the cross-market comparisons, and so health plans can see how they perform against their competitors.
Yep.
Other questions, Commissioner Leibman?
Yeah, thanks, Senior Director Arbeck, for going through this. We could spend the whole day probably going through some of these slides. It's fascinating the amount of data that you have, and I'm really looking forward to the continued dialogue on this and the trends. The one thought I had, just to build on a couple of the points made, was I know our effort here and our desire is to seek out policy solutions, but it just caught me a little bit on one of the comments a moment ago that there's so much change happening right now at the federal level and in different policy efforts. And the data is always lagging, but it would be good also, in addition to some of the discussions that'll come out next month, to just capture for you and your team what's the canary in the coal mine research areas that we should be looking at that would be the first moving signals that some of our worst fears are being realized, or perhaps they're not. And I'd like to help with that, because that's, to me, is like we're making conclusions on some of the downward consequences of some of these things happening right now, and we need to find information to help really support the movement that would happen, and that would support a lot of the policy directions that may be necessary.
Great, I agree.
And two last comments or questions on this topic, Commissioner Wilmoth and then Commissioner Walsh.
Yeah, so I just had a comment, really more than a question, which was that it seems to me that the numbers that are presented in this slide don't really justify the headline here, which is, the share that were eventually avoidable increased. I mean, if you drop 20 in 2021 with the COVID impacts, it seems to me that the percentage is pretty steady. I would guess maybe not even a statistically significant change from 39.9 to 40.5. I mean, it's around 40%. And it's been pretty steady since 2016, if you take out the 2 COVID years.
That's fair.
So yeah. So I don't know. I guess I question whether that's the right headline. And then my second point is, is there more that can be pulled out of this number? To me, it looks like the number of ED visits per 1,000 residents has held pretty steady since 2022, 2023, 2024. They're pretty much the same. There was a significant drop with the pandemic. Then there was a recovery over 2 years or so. And since then, it's been pretty steady. I wonder what that says about our emergency department system, particularly since, as David said, we've lost 4 emergency departments. So I guess I just would urge you to sort of take a little bit of a deeper dive into this slide. I think it's a very important topic, ER overuse. I just want to be careful about how we're sort of interpreting the data when we say, there's the avoidable has increased. Is that a real increase or is that a statistically insignificant increase? And what else does this data show us about ER use and where it's trending? So that's my comment.
Sure, I appreciate those points. And we wouldn't take just one slide like this to launch a policy intervention or program. It's really just, this is kind of the sort of some top line results, but I'll note that we have a report coming out soon on behavioral health ED boarding. And what you don't see in this data is the length of time people are spending in the ED has grown, and we have that in other places. And it is kind of reflecting what David Seltz said, that even though visits are steady the last few years, the ED capacity has gone down. So these wait times are just, they're terrible. As Steve Walsh said, they're terrible for patients, they're terrible for the entire system. And so we're certainly working on, as well as the rest of the government, as ways to address that problem. But I take your point that the percentage avoidable hasn't really grown that much, but it's objectively, I would still call that high, and something that I think we do have tools, not easy ones, but there are tools throughout the system that we can use to try to address that problem in itself.
Absolutely. So the story is, the problem still exists and it's almost as bad as it was 10 years ago.
Mm-hmm.
But maybe it's not, that it continues to get worse, which is what the headline suggests.
Well, I take your point on that. Thank you.
Yeah, and more to come. Absolutely. And then Commissioner Walsh, and then we'll just do a time check on this topic that will begin to move to closure on findings. Commissioner Walsh.
Thanks, Madam Chair. Thanks, Dr. Ryback. Look, I think Commissioner Ulmer was right, but there can be two truths. And I go back to what Commissioner Caljo said. I mean, if we just simplify this down to one basic point, if the emergency department is your front door to healthcare, we have a problem. And I think that what David's point can be is, even if things are constant, to what Jamie said, inflationary costs of care are up, workforce challenges are up, creates longer wait times, drives up the cost of care, and makes affordability challenges even more. We've been discussing for 2 decades price variation and all the other things that are outlined in the chart. But on this slide, I think if we can focus on getting folks in the healthcare system at a point of entry that isn't the ED, we will solve a lot of our problems and see some immediate relief to our patients and to the cost of their care.
Great. Thank you. Agree. Okay. I think there's maybe a couple more and we can just, close out. That's great. Okay. This one, I'll just say a couple words about. We show this chart year after year, and it's fairly simple. And what we're just showing is the concentration of care in a small number of hospital systems as time goes on. And what this is showing is just take the 6 largest hospital systems in any given year and count what percentage of inpatient stays take place in those systems. And you can see in 2016, it was about 62% of all stays, and that has gradually gone up, as there have been the BILH merger, and you can see Steward disappearing in the very last year and UMass becoming the 3rd largest share. Overall, that share has slightly increased now to 71%. And this concentration, folks have found over time, it tends to lead to higher prices. Okay, and I think there might be one more, or we might be done. Let's go to the next slide. Okay, that's right. This one is, I'll just skip over this one. It's just showing trends in discharge after a hospital stay to the array of routine care, home health, which has been shrinking, and institutional care. I can't help but saying that home health does point to a point that we made earlier, where the number of workers in the home health sector in the state has really shrunk drastically since the pandemic, which is untrue in the rest of the country. So we really have a problem finding home health workers to care for these folks, and that is probably related to why that blue line is going down. Okay. Oh, I forgot. I'm sorry. There's one final section, but I can be really quick, Deb. Just
Yeah, no,
getting some of the highlights of this.
absolutely. It's painful to constrain this topic because
I
as one of
know.
the other commissioners said, I feel like on every one of these, it could warrant a deep and rich conversation. So
I understand. I'll just give a quick overview to what's happening here. So the fourth section of the chart pack is where we compare provider organizations to each other based on the patients that they serve and the spending and care utilization of those patients. So this starts with the APCD, and we attribute patients to provider organizations through their primary care in the same way an ACO would do the same thing. And so here, at the top line, we're comparing the total spending for patients by the organization that they're attributed to, and you can see how that arrays. And there's pretty big differences in spending, whether you adjust for patient health status or not. It's about 30 to 40% difference in total annual spending for those patients, from MGB on the left to Reliant or Baystate on the right. And then we can compare other characteristics of these provider organizations, for example, and their performance by comparing their collection of patients. Let's continue on, please. For example, use of imaging. Again, an area where we know there is sometimes overuse of imaging. There are some low-value care measures targeting excess imaging. And we just want to compare those rates of imaging by the same provider organizations. And you can see about 20 to 30% difference adjusted for patient health status in use of MRIs and CTs. Okay. And finally, we compare organizations on low-value care. We're not showing the provider by provider on this slide, but this is the overview to the low-value care section, where we collect from the literature, I think, about 20 different low-value care measures. This is care that really just has no benefit to patients at all, and it's very sort of stubborn or persistent, which we found year after year. We found that about 9% of patients in the APCD received at least one low-value care service, and that amounted to more than $20 million worth of spending. And that's just for the folks we see in the APCD, which is about 40% of the total commercial universe. So it would be more than 50 million if we thought about the whole commercial population in the state. And this low value care provision and total spending varies by provider organization. And you can see all that variation in the chart pack, also in a Tableau version, so you can choose your own measure and see how the groups compare. Okay, now I'm really done.
Okay. Fantastic work. Other comments or questions from the commissioners? Obviously, this is the beginning of a review of our annual report, and more to come.
Say it's not a question, but a compliment. These are always so interesting, providing like really rich context and understanding about what's happening in the state. So I value them as an academic and use them in teaching. And so definitely appreciate this view into our health system.
Yeah, I was going to say the exact same thing. This is just amazing information. And David, particularly for you, as you set the stage, it's important to remind everybody how much of a system solution is required. It's not, hospitals doing X or health plans doing Y. The health system as a whole has to step up to really reduce variation. And if there's a way to construct, the opportunity, it would be helpful to get, to have a headline number, which is going to be really big.
Mm-hmm. Yeah.
And a good teeing off point for the cost trends hearing, given our theme, which is how do we work together around affordability. So I think that's an important observation. Thank you. Any other comments or questions for Dr. Auerbach before I turn it over to Executive Director Seltz to summarize this section. Okay, we'll turn it over to you.
Thank you, Madam Chair. And as far as next steps go, as David Auerbach said, we will be sharing the full report with you and the chart packs for your review and input in the coming weeks, and look forward to being able to finalize this year's report and issue it. And alongside that, with each year's report, we also include a section of policy recommendations. And so these recommendations can be to a range of actors. It can be recommendations for policymakers like the legislature. It can be recommendations for actions that market participants should take. And it can be recommendations that government agencies should take. So last year in our recommendations, we really focused them on strengthening and expanding market oversight, including expanding our material change notice process and our registration of provider organization program to include private equity investments in healthcare and real estate leaseback arrangements. We also recommended revitalizing state health planning and conducting focused assessments of supply and need and distribution of healthcare services. And we were so grateful and pleased to see that the market oversight law that passed earlier this year included provisions addressing many of these recommendations that were included in last year's report. In addition, the prescription drug bill earlier this year included many provisions that were consistent with some of our past HPC recommendations regarding increased transparency of pharmaceutical manufacturers and PBMs. We had made past recommendations about PBM licensure, which is now with the Division of Insurance, and made recommendations about including these entities in oversight authority like the cost trends hearing. Those were included in the laws that passed earlier this year. So I wanted to begin a conversation today, and I think this was just the beginning of a conversation around where we want to go with our policy recommendations for this year's report. I do think that I think the conversation at the cost trends hearing is going to be really helpful for us to think about what we want to prioritize for our policy recommendations in this year's report. So I want to begin the conversation today, but I want to recognize that I think that's going to be a really important input from what we hear from market participants, as has been urged earlier, what we hear around concrete solutions, what we hear around where there is opportunities to take action, I think could be really valuable input as we think about putting together our set of policy recommendations. But I also did want to reflect on areas that we have made policy recommendations on in many of our past years in our cost trends report, where they were either not included in the bills that passed earlier this year, or perhaps where some additional work could still be needed. So I will not walk through each of these 8 buttons on this slide. I think they are at a very high level, and I think they're, in some cases, pretty self-explanatory, but I'm happy to kind of talk in more detail about what we have said in the past on each of these topics. But I'll pause here and entertain any initial reflections or thoughts that commissioners have in terms of what potential priority areas that you think we should be thinking about as we start to develop our policy recommendations for the cost trends report. What of these areas that have been past priorities that are still needing to be addressed, or other thoughts and reflections as we put together the cost trends report recommendations this year?
David, just a reaction to you. As I think about the sort of the healthcare system as a whole, it is truly in a crisis mode right now, right? And I wonder if the focus ought to be on the here and now, right? And think about things like what's going on in the ERs, primary care access, and should we not think about picking sort of 3 crisis areas, the whole system on those 3, solving the 3 crisis areas, as opposed to these are all really good stuff. I mean, I get it. Long term, you got to work on these issues, but I'm just trying to straddle the here and now with the longer term.
Mm-hmm. Yeah.
Yeah, it's interesting. It's exactly where I was going as well, in the sense of it may make sense to have some initial, very limited but focused ideas and thoughts around particular topics of concern, but then revisit based upon a review of emerging data earlier than maybe we ordinarily would, because of the dynamism and the sense of change in the market that we expect to continue to see. It's hard because it takes so long to achieve reform, and particularly policy reform. At the same time, I think it's our job to be thoughtful and engaged with the stakeholders to make sure that we're not aggravating or otherwise making things worse inadvertently on an issue. So I think our care and attention becomes much more important now than ever. I harken back a little bit to the COVID time period where the HPC, I think, wisely took a wider lens to that time period. And I think it may make sense to do that again, with the exception of some things that really we simply can't put off anymore because they've reached a crisis point. Better to have 2 or 3 things rather than 8.
Mm-hmm. Yeah. Thank you.
Commissioner Erickson?
So I agree that things are changing fast, right? And so I often as an economist think, well, what is our comparative advantage as a body? Like, what are we particularly good at? And I think we have a real insight into getting the details right? So that is something that we can add value. And so when I look at, say, this slide that you have up here, I start at the upper right and I think about administrative complexity. And I think there's a real role there for us to take the lead and thinking carefully about how to reduce that. I have a colleague of mine and I've done some work on fragmentation, and any individual payer, any individual provider doesn't want to bear that cost of solving it themselves. And so somebody needs to convene a standard setting organization to kind of, even voluntary, but offer a path forward that would reduce that complexity. That's something I think this body, for instance, would be particularly good at thinking deeply about.
Mm-hmm.
Maybe I'll offer a slight counter to that, which is if we can pick issues that are of deep interest to, let's say, both payers and the delivery side, I think we're at a point where we might be able to move things faster, right? Like when you talk about reducing administrative complexity, it's a wonderful thing. We've been working on it for, God knows, 40 years now. And it's just hard to get both sides to get some agreement around what the heck that is, right? But if you say, look, I've got a problem in the ER, and it's going to benefit both hospitals and health plans, you ought to get support for that real fast.
Commissioner Wolf?
Thanks, Madam Chair. I think all of those comments are right. But I do go back to Commissioner Caljo's comment. I mean, we are at a seminal moment in healthcare, and I do think that the group has the ability to have an overarching theme for the year, and then have other priorities. And I think if we think that the overarching theme of the year in this moment is access to care, whether that be through coverage or affordability or patients not being nervous to go and get care they need because maybe they are immigrants or in a protected status. I think if we think about it in the terms of what we should wake up and focus on every day, and then also be able to focus on other really important priorities that have been HPC initiatives over the course of the last decade, I wouldn't want to be having a conversation about solving problem X while 200,000 people are losing their insurance coverage and appear completely tone deaf to what's happening in our healthcare ecosystem. And I think we can do both at the same time.
In part of that access question is the ability to get care affordably. And so I think we can tie those in a little bit to the questions presented by the changes in enrollment and access, and drive at that, because in my mind, at least, I think that reaches a parallel intensity of urgency for sure. But that's just my opinion.
Yeah, and just to add on this one, I mean, with these chevrons, we can't lose the cost offsets that we see from some of these things, because I just envision us talking about a number of different investment areas, and it is truly investments in our healthcare. But it would be wonderful if, you know, with the help of MHC, we can determine areas where we see either short-term or long-term. And I don't want this to become just a short-term only focus, which is, you know, this is going to be a long-term effort and there's near-term solutions, but there's also, what do we want this to look like 5 years from now, 8 years from now? And I just think sometimes we can lose, like, what are we offsetting here when we make the investments that we do? And I think for each one of these, which areas we're going to prioritize, it's crucial that we have a way to explain that.
Mm-hmm. Yep. Yeah. Thank you.
Commissioner Harding?
Really good conversation. I'm my brain is going in 4 different directions right now, but it's all really good and something, again, we're very focused on here at HHS as well. The piece that I feel like I'm missing, and we discuss around our offices here at HHS, what's happening in other parts of the country, and are there any pockets or areas that are doing it particularly well or better than us? And if so, what can we learn from them? And I just, you know, we get so caught up in, you know, focused on our market, which is where we live, and, you know, we all apply our skills and our efforts. But what's happening? What's happening in the Southeast, the Southwest, the Midwest? I don't have a strong sense of that. And I think that would really help to inform a lot of these conversations.
Yeah, good point. Where are our challenges different, and where are the solutions helpful? And where do we have some unique challenges versus just experiencing what could be a national issue?
100% agree with that.
Other thoughts, comments, or questions? We'll certainly come back to this, as Executive Director Seltz said, as part of digesting the input at the cost trends hearing.
Yeah, thank you so much, commissioners. And this was really kind of exactly the right type of initial feedback that I was looking for, kind of structural and thematic, as we start to think about this, and really helping kind of give that big picture feedback. I'm glad this is recorded. I'm going to go back and, you know, watch this again and think about all your comments again. So thank you so much. Deb, I think I have the next agenda item, so if I'll just keep us moving.
Of course, thank you.
So up next, we're going to move to just a piece of business for the Health Policy Commission, which is our annual budget. So next slide, please. So our annual operating budget is established every year in the annual state budget through an appropriation. This is set by the legislature and approved by the governor. The way that our statute is set up, after there's an appropriation set by the legislature, we do have an assessment that we apply to different industry participants. We collect that revenue, and that is used to offset the state's appropriation. I will note that assessment calculation changed in the new legislation, and that's going to require us to change the regulation and the process by which we do that assessment calculation. And we're going to come back at a later meeting to bring that to you and discuss the changes of that. That doesn't impact the appropriation itself. So for last year, our appropriation was around 12 million. And in this current fiscal year, FY26, our initial state appropriation was 12.4. And just recently, as recently as today, recognizing that we had expanded responsibilities mandated by the new healthcare legislation. The legislature is moving forward an additional $750,000 into that appropriation for a total of 13.2. We're extremely grateful to the legislature and our legislative partners for their support to being able to get to this particular budget number. So I'm going to share a little bit about the plan for this appropriation. So the agency, the HPC, we're primarily a staff-driven organization. And so as you can see on the next slide, about 68% of our spending is on staff. And so this, as you can see here, is the vast majority of our spending plan. This includes annualizing in current staff, as well as being able to hire a very few number for our increased new responsibilities as we phase that in. Another big part of our budget is our professional services. These are the contracted experts that we work with on a wide range of different projects, and that represents around 12% of our budget. Other aspects of our budget, admin, rent, IT expenses, are all quite small. Zooming in a little bit more on that consultant and contractor piece on the next slide, I've just kind of bucketed these into some broad categories just to give you a sense of how these, how we tend to work these divvy up. A lot of this is working with healthcare market economists, financial experts in the course of our healthcare market analyses. We have this year set aside some of our contractor budget for work specifically in the pharmaceutical market and work supporting our new Office of Health Resource Planning. I also, in this year's budget, you can see that there's a little bit of this consultant and contractor funding that is not currently committed. The reality of the work at the HPC is that it is unpredictable. And we don't know when we might get another market transaction review. We don't know when we might get a drug referred to us for review by Mass Health. And so that by nature often requires us to be a little bit flexible and a little bit conservative in how we spend our money, recognizing that we don't necessarily have control over what may come before us and what may require an intensive review. Next slide. So with this appropriation, I'm pleased to say that this will support maintenance of our core programs and activities, so our ongoing statutory responsibilities. It will support our ongoing market oversight, including the retrospective CMIR of Beth Israel Lahey and the current CMIR of the clinical affiliation between MGH and CVS Health. It will support a phased expansion of our new offices of Office of Pharmaceutical Policy and Health Resource Planning, with a support to hire 2 to 3 net new staff for these offices. Next slide. It will continue to support what we've already committed to in terms of our support for the primary care and maternal health task forces. HPC has been the staff support and research and analytics support for those 2 task forces that we work with EOHHS and DPH. It will support the new stipends for 9 of the board members. And as I said before, there is significant unknowns in each year. And so we always are thinking about what may happen. And if in any year there are unspent funds, the assessed entities that offset that state expense, they are credited that amount. And so they are not liable for that expense. Next slide. I just wanted to share a little bit about our staff headcount over the years. So as you can see, from 2016 to today, our headcount has been very stable, even as our responsibilities and mandates have grown. And that's really a reflection of the talent of this team. And so you can see, however, in this last quarter, a slight tick up as we have been able to begin to staff the 2 new offices. Next slide. So with that presentation, I will turn it over to the chair to happy to answer any questions, comments that any commissioners have. I turn it over to you, Chair, to lead the discussion.
Thanks so much. Any questions or comments from commissioners? So our role is really to consider the spending plan. We receive the operating budget and a decision is made, as Director Selt said, about what to allocate to us. So our role is really to consider, understand, and approve the agency's spending plan for that budget.
Deb, David, my initial reaction to the appropriation was that it was good, but didn't take into consideration the added responsibilities and staffing needed for the 2 new offices. So I think the additional appropriation that you mentioned probably deals with my concern, but other than that, I think the way you've laid it out is fine.
Thank you.
Thank you. And I think, as we heard in the presentation, management is constantly balancing, new initiatives as they come in and existing work, and that is happening throughout the year, and we'll get updates on that at the board if there are significant considerations.
Absolutely. Yep.
Any other questions?
Maybe Executive, since this is the first time I've seen the budget for this, or at least looked in detail, with being a newer commissioner, I was just curious, is there any, and I'm talking specific to the pie chart that had the variation on employee percentages, which is the largest versus the others. And I was just curious, I mean, is that the makeup that you want and you think is appropriate? Obviously, you've laid that out this year, but 12% on consultants and contractors, and then pretty much the rest on the employee base. Is that kind of the mix that you envision in the future? Is that kind of what you think it will take? Or, I'm just interested, even with the changes of how do you see this evolving over time? Or is that 12% kind of unstable?
Yeah, that's a great question. And it has changed over time. I think first, we do look at benchmarks in terms of what we're spending on admin and IT and that part of our budget compared to other state agencies. And we're well below those benchmarks, so I feel good about that. I think specifically on the consultant versus staff, there's always a little bit of question of build versus buy, right? And so when we were first starting the agency, we did rely a little bit more on some consultants and professional services. And over the years, we've been able to reduce that ratio as we've been able to build some of that professional capacity on our staff and bring in some data expertise that otherwise we were using consultants for, and having staff be trained up into that level of expertise. And so I think this year's budget reflects a little bit of as we're putting these new responsibilities in place, we're working with consultants to do so. So that may shift over time if we're able to build that capacity internal. But there are really specific niche areas of expertise in areas like the pharmaceutical market that it's appropriate to work with outside experts on. And so to sum up, I think we're in a good place right now, and maybe that would change a little bit over time as we stand up and get better at the new responsibilities.
But to follow on with that, I'm not hearing that it's a difficulty in hiring the right staff that's causing a need for consultants. It's really more around the efficient use of funds to access a particular area of expertise. But recruiting and hiring and retaining, I think, has been a strength of the HPC, and I don't think that's been a reason for needing to hire additional consultants.
Yes, thank you for that clarification, Madam Chair. We've been, I think, fortunate in this environment to be able to have a few opportunities to hire talented people, and there are a lot of really talented people looking to contribute in healthcare and contribute in government work and contribute in public service, and so we've had very, very competitive job opening applications recently. I'll just plug one. We do have an opening right now for our Office of Pharmaceutical Policy. So if anyone watching is interested, please check that out.
Great.
Yeah, and just to add on to Chair DeVoe, I've learned over the last 2 months, Executive Director Seltz, you must have like one of the most stable leadership teams and continuity over the last decade of any organization I've seen. So I think there is a strength there that's speaking to that.
Absolutely. I think that's a really important observation. As I've said before to the leadership team, the feedback that I guess most frequently from our those who work with the HPC is that we have an incredible team. And this is from people that work in national research organizations who are, policy experts. They start conversations with me by saying, do you realize how lucky you are? And I certainly say yes, but I also think to myself, it isn't luck. I think it's been a very carefully built organization that is very well managed. So I really want to recognize the team for that. And Executive Director Seltz, of course.
All credit to Colleen, but thank you.
Good point. I think she would agree. That's a very good point. We all would. Other comments, observations, questions from any commissioner? Okay, hearing none, I think we can move to handle the roll call vote. Deputy Director Elstermeyer, can you manage that process?
I would be happy to, Madam Chair. Do I have a motion?
So moved.
And a second. Thank you so much. Starting with you, Madam Chair.
I vote to approve.
Thank you. Vice Chair Cohen?
Aye.
Commissioner Cotterell?
Aye.
Commissioner Erickson?
Aye.
Commissioner Kirkpatrick?
Aye.
Commissioner Leibman?
Aye.
Commissioner Walsh?
Aye.
Commissioner Wilmoth?
Aye.
Commissioner Caljo?
Aye.
And Undersecretary Harding.
Aye.
Thank you.
Thanks so much. And we'll now move to our last formal agenda item, our Executive Director's report.
Thank you, Madam Chair. Thank you, Commissioners. For our final agenda item in the Executive Director's report, we're going to move to our final lever, market oversight, and give you our standard market oversight update on material change notices. This will be our final agenda item, and we have an update on our RPO program, but this will be our final agenda item of the day, and I'm going to turn it right over to Sasha to lead this section.
Good afternoon, Commissioners. For those of you who I haven't had the pleasure of meeting in person yet, I'm Sasha Hayes-Rusnov. I'm Associate Director of Market Oversight and Monitoring within our Market Oversight and Transparency team. Our team leads analysis of proposed changes on spending, market dynamics, quality, and equitable access to care, and I've had the privilege of being a part of that work for coming up on 12 years now. As Director Seltz said, this is our usual update on market transactions. Since 2013, the HPC has reviewed a total of 193 proposed transactions under our material change notice process. Of these, as you see here, transactions involving mergers, acquisitions, or contracting network affiliations involving physician groups remain the most frequent, followed by the formation of new contracting entities. On the next slide, a reminder that HPC staff are continuing the cost to market impact review of the proposed affiliation between, the retrospective review of the impacts of the creation of Beth Israel Lahey Health, as well as the newly approved CMIR of the proposed contracting affiliation between Minute Clinic Primary Care and Mass General Brigham. Our team is working through our usual process in both cases of obtaining necessary information from those provider organizations, as well as other market participants to inform our reviews. On the next slide, other transactions that are currently under review in the material change notice process include a proposed joint venture between Milford Regional Medical Center, which is part of the Mass Memorial System, and Shields Healthcare Group to own and operate MRI and PET CT services at Milford. A proposed acquisition of the parent company of AmSurg, which is a private equity-backed ambulatory surgery center operator that operates across the country, including in Massachusetts, by Ascension Health Alliance, a national nonprofit healthcare system. The proposed acquisition of Kaba Fusion, which is a specialty home infusion services company, which similarly operates nationally, including in Massachusetts, by a newly formed subsidiary of the private equity firm Nautic Partners. And newly since the last board meeting, the proposed acquisition of Acton Medical Associates, which is a primary care practice with locations northwest of Boston, by Atrius Health, which, as you'll recall, is now affiliated with Optum Care. This is a subsidiary of United Health Group. That is our market update. Those are the transactions under review. No new transaction reviews have been closed out since our last board meeting. I'll take any questions, but otherwise, back to you.
I guess I will chime in and wonder, kind of high level, as you approach modeling or just assessing some of these, how do you think about the conversion from nonprofit to for-profit status, or vice versa, as we see here, and its impact on spending?
Yeah, it's certainly something that we have an eye on, obviously, in the nonprofit to for-profit space. That's also something that the Attorney General's office has some oversight over. And so we make sure to make use of collaboration with our agency partners in those cases. And we also make good use of discussion with those expert economists that were being discussed earlier. And, additionally, we look at the market behavior of these entities and try to assess based on prior behavior, both here and elsewhere, what we think might be likely to happen as a result of any given change.
Thank you.
Great. Moving us right along, I'm going to turn to Liz for an update on our registration of provider organization program.
Good afternoon, commissioners. I'm Liz Reedy. I'm a senior manager on the market oversight team. I've been at the HPC since 2014, so since the early days of the RPO program that I'm going to tell you about. So the RPO program is a data collection program established by Chapter 224 that is jointly operated by the HPC and CHIA. The program is designed to create greater transparency around the structure and relationships of Massachusetts provider systems, to track changes in the healthcare market over time, and to provide the public with access to the resulting data set. Approximately 50 provider organizations were required to register in 2024. These included all of the general acute hospital systems in the Commonwealth, as well as large physician groups and behavioral health providers that met the program's revenue threshold or that received a risk certificate from the Division of Insurance. The right-hand side of the slide shows the types of information that provider organizations have been required to report to date, including information on their corporate structure, contracting and clinical relationships, licensed facilities, physician network, financial performance, and payer mix. The data are used to support many functions, including transaction reviews, analyses for the cost trend report and other research publications, and the work of the HPC's new Office of Health Resource Planning, just to name a few. And data through 2024 are posted on the program website and are made available for public use. The next slide, please. So Chapter 343 made several key updates to the program that increase state oversight of private equity in healthcare and support the Commonwealth health planning efforts. So first, the statute lowered the revenue-based registration threshold from $25 million in commercial Medicare Advantage and Medicaid MCO revenue to $25 million in revenue from all payers. This change increases the number of providers that will be required to register with the program. The statute also directs the program to collect new information on provider organizations' relationships with significant equity investors, MSOs, and REITs. And the program, we may also require additional data and more frequent reporting from provider organizations with private equity investment. These changes are a direct response to the Steward bankruptcy and will help ensure that the Commonwealth can closely monitor the kinds of relationships and structures that led to the collapse of Steward Healthcare. And then finally, the statute also directs the program to collect the name, address, and capacity of all locations where the provider organization delivers care, which will support the HPC's health planning efforts. So in response to these statutory changes, we have updated the reporting requirements for the 2025 data collection cycle, which you can see on the next slide. So first, in conjunction with the updated registration threshold, we've expanded the types of providers required to register to include specialty, non-acute, and chronic care hospitals, urgent care centers, ambulatory surgery centers, freestanding imaging facilities, and clinical laboratories. Second, we added 2 new reporting requirements informed by public comments. So one includes identifying information on provider organizations' relationships with significant equity investors, MSOs, and REITs. And the second is a roster of advanced practice providers and behavioral health clinicians that are employed by the provider organization, similar to what we currently collect for physicians. And we expect to phase in additional reporting to fulfill statutory requirements over time. And next slide, please. And finally, I have an update on program resources for the 2025 filing. So we released the 2025 data submission manual and filing templates in September. The deadline for 2025 filings is Monday, December 1st. And program staff will host training sessions via Zoom next week. So the first session on Monday, October 27th, will focus on updates made to the reporting requirements for 2025. And the second session on Wednesday, October 29th, will be designed for new organizations or new reporters and include a full file-by-file overview. And provider organizations can email us at hpc-rpo@mass.gov if you would like to participate in one of the training sessions next week. And with that, I'm happy to take any questions or to turn it back over to Director Seltz.
Any sense of the, Commissioner Calgill, please.
Sure. No, go ahead.
Just a question about, is it too early to have gotten any feedback from the new providers that are going to need to respond about their response to this? Is it too early to have any sense of that?
We have had some outreach on our end to the provider organizations that we expected would meet the registration threshold, and we have had good responses from these organizations. So we've had, I think, some in all of the categories that I mentioned in the non-acute hospital space, couple urgent care centers, ASCs, imaging, and I think at least 1 or 2 labs as well. So I think we're expecting from that category probably around 10 new registrants. So a lot of positive communications from the organizations and staff outreach to those organizations.
Great. Commissioner Calgill and then Commissioner Wilmoth.
Sorry again for that intrusion. With reference back to slide 98, the last slide, on the individual clinicians that are on the roster of information, both new and ones that were previously required to register, do we ask, and I probably should know this, but I don't, do we ask for the information about whether they're taking patients actively, and would we ask for that information if we don't?
We do not currently collect whether they are accepting new patients, but are often considering ways that we can refine the data requirements. And so I think definitely something in consideration for future iterations, especially as we undertake the new health resource planning work, that might be something of interest.
Thank you.
I will just add, Commissioner, I think there, it is a snapshot in time, and so it's at one point in time. So something to think about.
Yeah, the only reason why I mention it is the same time consideration applies to provider directory information. And I wonder about whether we just parallel the requirements in both, just to be consistent across regulatory requirements. That's why I ask.
Commissioner Wilmoth?
Thank you. I just had a question about, do you have enough guidance directive from the legislation around what is a private equity company, what is an SEI, what is an MSO, what is a REIT, enough that you're satisfied that you're getting reporting from the correct entities, the full set of private equity entities, however it's defined. Have you defined that yourself? I guess it's a question both for Liz, Sasha, maybe even for David. I know it's a very, very complicated area, and there are varying definitions of what a private equity company might be. So I'm just wondering if you've made enough progress, you think, on that, if you feel like you're prepared to start collecting that information and start monitoring those activities as envisioned by the law, but maybe not as carefully directed as it could have been, if that makes sense.
Sure. We, at least in this first year of data collection on this information, have gone mostly with the statutory definitions of these terms. I think in some cases provided, like with an MSO, for instance, some examples of the types of organizations we would expect to be reported here, and others that may meet the statutory definition that providers don't need to tell us about, such as a financial audit firm, for instance. We don't need them to tell us about those types of relationships. I definitely think that this first year for RPO is going to be a huge learning experience about what's reported. And I think the questions that provider organizations have for us ahead of the filing deadline might help us to think about some things that we also don't know in this space. So I think to answer your question, I think we have a starting point from the legislation, but I think there's a ton for us to learn as we go.
Lois, did you want to add anything?
Oh, just to mention that with all the learning we're going to be doing this year, we do have an opportunity to expand as necessary and give more examples in the regulatory process. So we are going to be promulgating regulations very much in conjunction with CHIA on the RPO program that we implement together.
Thank you. That's helpful from both of you.
Commissioner Erickson?
So very exciting. I think it's another example of Massachusetts like leading the way and providing a really new insight into things. I wanted to follow up on Commissioner Calgiu's comment because I think it's an opportunity to really think about administrative costs and also getting accurate information about who is accepting patients and who is in what insurer networks. Because we clearly do network adequacy regulation, and there's been a lot of concern nationally about payers not accurately reporting their provider networks. And if we are getting providers to register, it seems worth thinking about a small amount of additional effort to collect some very valuable data that would inform network adequacy regulation and help consumers see who's actually in network.
Yeah, I think that's a great point. And you've really highlighted one of the sort of core principles of the program, which is in determining the data collection, thinking about the burden on provider organizations and weighing that with the utilization of the data.
Other comments or questions or thoughts? Thank you so much, Liz. Any last observations, Liz, before we close
No,
on
just
this?
thank you all for your great questions.
Thank you.
Thank you, Liz. And for our final slide of today, our standard other recent and upcoming publications. We've got a lot in the upcoming space. Recently released today on our website, Pharmacy Deserts. Go check that out. Play with the maps. Very exciting. Great meeting today. Thank you so much, commissioners, for all your feedback and insights. Up next is the cost trends hearing. So we look forward to seeing you all in person for a wonderful day. Turn it over to you, Deb, to close us out.
Yes, just re-emphasize as you did the cost trends hearing on November 12th, and a reminder that those who want to attend in person can sign up at our website. The hearing will take place from 8:30 to 4:30 at Suffolk University. And then our next HPC board meeting will be held on Thursday, December 11th at noon. That will be the final convening of the commissioners during 2025. So with that, let me thank everyone for an action-packed meeting, a robust discussion, and to thank those who tuned in on the live stream.